think for a moment about losing your sight. Not, suddenly, but slowly, silently.
Without you even realizing it's happening, especially in the early stages.
Exactly. That's the reality for millions around the world living with glaucoma. It's often called the silent thief of sight.
It really is. And it's the second leading cause of blindness globally. That's a huge number.
It is. And here's a truly sobering fact. Many people, maybe even half, have it for years without any symptoms at all.
Yeah, it's like a hidden leak, isn't it?
Huh.
Causing serious damage before you even spot the first sign.
So when you hear glaucoma, I think most people immediately think high eye pressure.
Right, that's the common association. And elevated pressure, what we call intraocular pressure, or IOP, it is a major piece of the puzzle, a very important one.
It's the main thing we can actually treat right now, isn't it?
It is. It's the only significant factor we can currently modify with treatment. But, and this is really key, glaucoma is much more intricate than just that single number.
Okay. So it's not just one disease.
No, it's actually a group of eye conditions, all linked by this progressive damage.
Right. So it's not simply about the pressure gauge reading too high. And our goal today, looking through all this great information, is to really get to the heart of this silent thief.
To go beyond just basic awareness.
Yeah, we want to give you a really comprehensive picture what glaucoma actually is, what triggers it, what treatments look like, and, what the future might hold.
Sort of filtering through all the complex stuff and pulling out the crucial knowledge, making it clear and hopefully engaging too.
Exactly. And if you step back, you see this isn't just some obscure medical thing.
Not at all. Given how widespread it is globally and the very real risk of irreversible blindness, well, understanding glaucoma is relevant for pretty much everyone.
So what's our plan for this deep dive? Where do we start?
Well, we'll begin by clearly defining glaucoma. Look at the mechanisms involved, the different forms it takes.
Okay. Then causes and risk factors.
Yep. Delve into the various causes and those crucial risk factors, why some people are more susceptible.
And we'll definitely investigate why it's so stealthy, right? Those early stages.
Absolutely. And how doctors actually diagnose it. Because if there are no symptoms,
How do they find it? Then naturally we'll cover treatments. The whole range.
from eye drops right through to surgery. We'll also touch on the role of lifestyle, what you can do yourself.
That's interesting. And what about research? New developments?
Definitely. We'll look at some of the exciting new directions in research. So by the end, you should have a much deeper, more informed understanding of this condition.
Sounds good. So the fundamental question then, what is actually happening in glaucoma that leads to sight loss? It's not just high pressure crushing the eye, is it?
No, not quite like that. It's more complex.
Okay, let's really unpack the core issue then. At its heart, glaucoma involves progressive damage to the optic nerve.
Right. Think of the optic nerve as the main cable.
Connecting the eye to the brain.
Exactly. It transmits all the visual information from your retina, that light-sensitive layer at the back, straight to your brain, letting you see.
So the real problem in glaucoma is the gradual loss of specific nerve cells.
Precisely. Specialized cells in the retina called retinal ganglion cells, or RGCs. These are the cells that actually see the light.
And they send the signals down those long threads, the axons?
Yes, they're axons bundled together to form the optic nerve itself, carrying the signals to the brain. Glaucoma is about losing these RGCs in their axon.
Okay, got it. But what's really intriguing, as you said, is that high IOP isn't always the defining factor.
Exactly. Take normal tension glaucoma, or NTG. Here, you get significant optic nerve damage and the characteristic vision loss. Even when the eye pressure is consistently within what we call the normal range, usually about 10 to 21 millimeters of mercury.
Wow. So that really changes things, doesn't it?
It does. It reframes glaucoma. It suggests it's more like a neurodegenerative disorder of the visual pathway.
Rather than just a plumbing issue in the eye.
Exactly. It's not solely about fluid pressure. It's about the nerve itself being vulnerable.
That's a really key distinction. So it's about the health and resilience of those nerve cells. Now, within this broad term glaucoma, there are different types.
Yes, several categories. And a primary way we classify them is based on the anatomy of something called the anterior chamber angle.
The anterior chamber angle, what's that exactly?
It's the little nook inside your eye where the colored part, the iris, meets the clear front surface, the cornea.
Okay.
And crucially, that's where the trabecular meshwork sits. Think of it like a tiny, intricate drain or filter.
So the fluid inside the eye, the aqueous humor.
Precisely. It allows that aqueous humor to slowly drain out. So based on whether that angle, that drainage area, is open or narrowed,
We get the main types?
We get the two main primary types, open-angle glaucoma and angle closure glaucoma.
Okay, let's start with the most common one. Primary open-angle glaucoma, or POAG. You said it's widespread.
Very. It's the most prevalent form globally, making up maybe 80 to 90% of cases in North America, particularly common in people of European and African descent.
So what's happening in POA? The angle is open, you said.
That's right. Anatomically, the drainage angle looks open. The iris isn't physically blocking the drain, the trabecular meshwork.
So the problem is the drain itself.
Exactly. The issue seems to be within the meshwork. Over time, it just gets less efficient at draining the aqueous humor.
Like that kitchen sink drain analogy slowly getting clogged.
Pretty much. This increased resistance to fluid outflow leads to a slow, gradual rise in the eye pressure.
And why does the meshwork decline? Do we know?
Not always, clearly. It could be age-related changes, maybe genetic factors making the meshwork weaker, or even issues at the cellular level within the meshwork tissue.
And this gradual clogging, that's why POA is just so insidious, right? It's so sneaky.
Absolutely, because it's usually incredibly slow and completely painless. You don't feel a blockage, no sharp pain, nothing.
So you can have ongoing nerve damage for years.
And have absolutely no idea until significant peripheral vision is already lost, often irreversibly.
That's chilling. And you mentioned it's more common in certain groups.
Yes. Besides European and African descent, there's a higher risk in the Hispanic and Latino communities too. And interestingly, urban living has been linked as a risk factor.
Urban living, that seems unexpected. Okay, now let's switch to angle closure glaucoma, ACG. Sounds quite different just from the name.
It is very different. Angle closure, sometimes called closed angle or narrow angle glaucoma. Well, here the issue is a blockage of that drainage angle.
Okay. How does it get blocked?
The outer edge of the iris, the colored part, actually moves forward and comes into physical contact with the trabecular meshwork.
So it physically covers the brain.
Exactly. It obstructs the outflow of aqueous humor, like pulling a plug over the drain hole.
And are certain eyes more prone to this?
Yes, typically eyes with specific anatomical features. Things like a shallow anterior chamber, less space between the cornea and iris,
Okay.
or a thicker lens inside the eye, or a shorter eye overall, what we call shorter axial length. These features are often found in people who are farsighted or hyperopic.
And is ACG as common as POAG?
No, it's a smaller proportion overall, maybe around 10% globally. But, and this is important, it's responsible for a very high number of severe vision loss cases. It can be quite aggressive.
And prevalence varies geographically.
It does. It's more common in people of Asian and Inuit descent. In fact, the Inuit population has the highest known prevalence.
And I understand ACG can present very differently too, sometimes dramatically.
Oh, absolutely. ACG can cause acute attacks. These are medical emergencies.
What does an acute attack feel like?
Imagine sudden, really severe eye pain, often described as excruciating. Blurred vision comes on quickly, maybe seeing rainbow halos around lights.
Wow.
Nausea, vomiting, a bad headache are also common. The eye itself might get very red, the cornea cloudy.
And the pupil?
The pupil often gets stuck in a mid-dilated position, not reacting to light. And crucially, the IOP skyrockets. We're talking levels of 50, 60, even 80 millimeters of mercury or more.
That sounds terrifying. Definitely an emergency. But can angle closure be less dramatic too?
Yes, it can. ACG can also present in chronic or intermittent forms. You might get temporary blurred vision, maybe see halos in dim light, or have mild eye pain or headaches that come and go.
And those milder symptoms are still warning signs.
Definitely. They shouldn't be ignored. They can signal that a full acute attack might happen later. Okay. Prompt evaluation is needed.
Okay, so POAG is the slow, silent type. ACG can be sudden and severe or more intermittent. What about secondary glaucoma?
Secondary glaucoma, as the name suggests, means the glaucoma, the high IOP and nerve damage, is a direct result of some other identifiable underlying condition.
So it's not the primary problem, it's a consequence.
Exactly. And there are quite a few potential causes.
Can you give some examples?
Sure. Traumatic glaucoma can happen after an eye injury, blunt force, or something penetrating the eye. The damage to the drainage structures can raise pressure, sometimes right away, sometimes years later.
Okay, injuries. What else?
Neovascular glaucoma. This is often a complication of poorly controlled diabetes or maybe a retinal vein occlusion. Abnormal new blood vessels grow over the iris and the angle.
And block the drain.
Precisely. They physically obstruct the outflow. So you see, the trigger varies, but the common theme is something disrupting the eye's natural drainage system.
That sounds very serious, especially with conditions like diabetes. Any other causes?
Yes. Uveitic glaucoma can result from inflammation inside the eye, called uveitis. Steroid-induced glaucoma can happen from long-term use of corticosteroid medications.
Pediatrics can do that.
Sometimes, yes. They can affect the drainage system in susceptible people. Then there's pigmentary glaucoma.
Pigment, like from the iris.
Exactly. Tiny pigment granules flake off the iris and clog the meshwork, often seen in younger, nearsighted men. Sometimes pressure spikes after exercise.
Interesting. Keep going.
Pseudoexfoliative glaucoma involves a flaky, sort of dandruff-like material building up and clogging the drain. This one can be quite aggressive. Lens-induced glaucoma can occur if, say, an advanced cataract makes the lens swell and push the iris forward, closing the angle.
So the lens itself causes the blockage.
In that case, yes.
Yeah.
And finally, there's congenital glaucoma, which is rare and present at birth due to the drainage angle not developing correctly.
Wow, that's a really wide range of secondary causes. It truly highlights that glaucoma isn't always just about the eye's primary drainage system failing on its own.
Exactly. And understanding these different types and their causes is absolutely vital for getting the diagnosis right and choosing the best treatment.
So we've got a good handle on the optic nerve damage. Now let's dig into why. What are the known causes, and what makes some people more likely to get glaucoma?
Well, as we've established, that elevated intraocular pressure, IOP, is still the most consistently identified and, frankly, significant risk factor for most types of glaucoma.
It puts stress on the nerve fibers.
Right. When the pressure inside the eye stays too high for too long, it increases the odds of damage. We often call IOP over 21 millimeters G ocular hypertension.
And ocular hypertension increases the risk.
It does. Roughly 10% of people with untreated ocular hypertension might develop glaucoma within about 5 years.
But we know high pressure isn't the whole story, right?
Right.
Especially with normal tension glaucoma.
Correct. So impaired aqueous outflow is the direct cause of the high pressure in most cases. We talked about the clogged filter in POAG, the physical blockage by the iris in ACG,
Right.
and the obstruction by pigment, inflammation, blood, or new vessels in secondary glaucomas.
But then there's the nerve itself.
Yes, optic nerve vulnerability. That's key, especially in NTG. Some optic nerves just seem inherently more susceptible to damage, even at normal pressures.
Why would that be?
It's complex and still being heavily researched. It likely involves a mix of things. Genetics, the structure of the lamina cribrosa, that's the sieve-like plate where the nerve exits the eye.
Okay.
The blood supply to the nerve, how well that blood supply self-regulates, even the health of the support cells around the nerve fibers.
And genetics. That seems like a really big piece of this puzzle.
Huge. There's a significant hereditary component. Specific genes linked to both IOP and optic nerve health have been found for both POAG and ACG.
So family history is a major warning sign.
Absolutely. Having a positive family history, especially a first-degree relative, parent, sibling, child, is one of the strongest predictors. It can boost your risk 4 to 9 times, maybe even more.
4 to 9 times, wow.
Yeah, and specific genes like MYOC, CYP1B1, LOXL1 have been identified, plus many other genetic locations are under investigation.
So if my parent has glaucoma, my own risk is way up there. That's critical information. Okay, beyond these direct causes, what are the other key risk factors?
Age is definitely a big one. The risk, especially for POAG, goes up quite a bit as we get older.
When does it become more common?
It's much more common after 40, and the risk really jumps after age 60. People over 60 are maybe 6 times more likely to get it compared to younger folks.
That explains why baseline screening is often recommended around 40.
Exactly. Then there's race and ethnicity, which we touched on.
Right. Can you recap that quickly?
Yeah. Sure. People of African descent have a higher risk of POAG, often starting earlier and being more aggressive. Hispanic or Latino descent also means higher POAG risk.
Okay.
Asian descent carries a higher risk of angle closure glaucoma, and Japanese descent specifically has a higher rate of normal tension glaucoma.
And the Inuit population.
Highest known prevalence of angle closure glaucoma worldwide. So your background really matters here.
Definitely. What about eye characteristics, things specific to the eyes themselves?
Well, high IOP or ocular hypertension, obviously. Also, having thin central corneas seems to increase risk.
Thinner corneas, why is that?
It can affect pressure readings, but it also seems to be an independent risk factor, maybe indicating weaker structural tissue overall. High myopia or nearsightedness is linked to POAG risk.
And farsightedness.
Hyperopia or farsightedness is linked to angle closure glaucoma risk. Even just how your optic disc looks during an exam can give clues about risk.
Interesting. What about overall health conditions, systemic issues?
Yes, certain conditions are linked. Diabetes roughly doubles the risk of POA.
Doubles it.
Yes. High blood pressure, heart disease, and obstructive sleep apnea have also been associated with increased risk.
Sleep apnea? How?
The exact link isn't fully clear, but it might involve fluctuations in oxygen levels or blood flow affecting the optic nerve. Long-term use of corticosteroids is another risk factor.
We mentioned steroid-induced glaucoma earlier.
Right. Previous eye trauma, of course. Lens thickness, like with cataracts, can narrow the angle for ACG. And that urban living factor for POA is still there.
And gender.
Men seem to have a slightly higher risk of POA compared to women.
So it's this really complex mix of genes, age, ethnicity, eye structure, and overall health.
It really is. Understanding these risk factors is just so crucial for proactive screening and catching it early.
Now, we keep calling it the silent thief, and for good reason. Why is it so stealthy? What's happening unseen in those early stages?
That insidious nature, especially with primary open-angle glaucoma, is exactly what makes it such a challenge. In the beginning, people typically have absolutely zero warning signs.
No symptoms at all.
None. Vision seems clear, no pain, no discomfort, nothing. And this symptom-free period can go on for years.
While the optic nerve is being damaged.
Silently, progressively, irreversibly damaged. Without the person having any clue. It's like that slow leak behind the wall damage is happening, but you don't see it until it's pretty bad.
So you're losing nerve fibers, but you don't feel or see anything different.
Exactly. And chronic angle closure and normal tension glaucoma can also start silently. That's why the nickname fits so well.
And the statistic is that up to half of people with glaucoma might be undiagnosed.
That's the estimate, simply because they feel and see fine initially.
Which really drives home why waiting for symptoms is so dangerous.
It is, because the damage is permanent. We can't regrow those nerve fibers yet. Waiting for symptoms means significant, irreparable harm has likely already happened.
So the only reliable way is proactive screening.
Regular, comprehensive eye exams, especially if you have risk factors. That's the only way to catch it early when treatment is most effective.
So eventually, what vision changes might someone notice as it progresses, say with POAG?
As more nerve fibers get damaged, the effects start showing up in your peripheral, or side, vision. That's the hallmark.
Gradual loss of side vision.
Yes, a slow deterioration. It typically develops over years, might affect both eyes, maybe differently in each. You start getting blind spots.
Scotomas.
That's the term, yes,
Yes.
scotomas. Initially, they often go unnoticed because they're in the periphery, and your brain is amazing at compensating.
It fills in the gaps.
It does. It essentially paints over the missing bits, so you still perceive a whole picture, which unfortunately further delays realizing there's a problem.
So blind spots are forming, but my brain masks them. Clever, but dangerous.
Precisely. Later on, as more damage occurs, you might find it harder to adapt to changing light levels going from bright to dim, for instance.
Okay.
And the classic late-stage sign is tunnel vision. Your central, straight-ahead vision stays okay until very late.
But the sides close in.
Exactly, like looking through a narrow tunnel. Severely constricted peripheral vision.
That's a really stark image. Now, you mentioned the dramatic symptoms of acute angle closure glaucoma earlier. Can you recap those key warning signs again? They sound hard to miss.
They usually are. An acute attack typically brings sudden, severe eye pain, a deep, throbbing ache.
Okay.
Vision becomes blurred very quickly. Seeing rainbow halos around lights is classic.
Halos.
A bad headache, often on the same side as the affected eye, sometimes mistaken for a migraine. Nausea and vomiting can happen too because the pressure spikes so high.
And the eye looks different.
Yes, the white part gets very red. The cornea might look hazy or cloudy. The pupil often gets fixed, mid-dilated, and doesn't react to light. And the IOP is extremely high.
Definitely sounds like a 9/11 situation.
Right.
What about those milder, intermittent angle closure episodes you mentioned? Subacute attacks.
Right, those are important too. People might get brief episodes of blurred vision, see halos, maybe mild eye pain or headaches, often triggered by dim light when the pupil naturally gets bigger.
And these might go away on their own?
They might, which is why people might dismiss them. But they are critical warning signs that a full acute attack could happen. They need prompt checking by an eye doctor.
So even fleeting symptoms shouldn't be ignored. Now, are there any other, maybe less specific symptoms people might experience?
Some people report a vague feeling of pressure or just general discomfort in their eyes, maybe occasional non-specific headaches.
But these aren't reliable signs.
Absolutely not, especially for POG. They're often subtle or completely absent. You cannot rely on feeling pressure to know if you have glaucoma.
So the lack of early symptoms is the real danger.
Precisely. Which brings us back to regular eye exams being so critical for catching it early.
Okay, so if the early signs are often invisible to the person, how do eye doctors actually diagnose it? What's in their toolkit?
Well, diagnosing glaucoma isn't about just one single test. It's really a combination of clinical assessments and specialized tests, putting all the pieces together.
No single magic bullet test.
Exactly.
So what are the main tools? Measuring eye pressure, tonometry is one, right?
Yes, tonometry is fundamental.
Yeah.
Measuring that intraocular pressure. The gold standard is Goldman applanation tonometry.
How does that work?
After numbing drops and a yellow dye, the doctor gently touches a small device to the front of your eye, the cornea, to measure the resistance, which tells us the pressure.
Are there other ways to measure pressure, like the air puff test?
Yes, the non-contact air puff is often used for screening, but it can be less precise. There are also handheld devices like the TonoPen or rebound tonometers like the iCare.
And we know the normal range is roughly 10, 21 milli-Hg, but high doesn't always mean glaucoma, and normal doesn't rule it out.
Precisely. And corneal thickness matters too. A measurement called pachymetry checks cornea thickness, which helps interpret the IOP reading more accurately. Thicker corneas can give artificially high readings, thinner ones artificially low.
And pressure changes during the day.
It does. So sometimes doctors do a diurnal curve measuring pressure multiple times over a day, or even use 24-hour monitoring with special contact lenses or home tonometers.
Okay, so pressure measurement is key, but just one piece. What else?
Yeah.
Examining the eye directly.
Absolutely. Gonioscopy is crucial. That's where the doctor uses a special mirrored lens on the eye surface to look directly at the drainage angle.
To see if it's open or closed.
Exactly. Essential for classifying the type, especially angle closure. Then there's ophthalmoscopy, examining the optic disc and nerve fiber layer at the back of the eye.
Usually after dilating the pupils.
Yes, dilating gives a much better view. The doctor looks for telltale signs of damage.
Like what specifically?
An enlarged cup-to-disc ratio. The optic disc has a central depression, the cup. In glaucoma, this cup often gets bigger relative to the whole disc.
Okay.
They look for a thinning of the neuroretinal rim that's the healthy nerve tissue around the cup. Sometimes tiny disc hemorrhages or splinter hemorrhages, especially in NTG.
And they photograph this.
Often, yes. Optic disc photos create a baseline to compare against over time, looking for changes for progression. They also look carefully at the retinal nerve fiber layer itself for any thinning or defects.
So visually inspecting the nerve for damage. What about testing how well I actually see? My visual field.
Yes, visual field testing or perimetry. This measures your peripheral vision, the functional impact of the glaucoma.
How does that work? The flashing lights test.
That's the one. Usually automated perimetry, like the Humphrey Visual Field Analyzer.
Right.
You sit, focus on a central light, and press a button when you see small lights flash in your side vision.
And it maps out blind spots.
Exactly. It creates a map showing areas where your light sensitivity is reduced. Glaucoma causes characteristic patterns like a nasal step, and arcuate scotoma, arc-shaped, or paracentral scotomas near the center. Eventually, tunnel vision.
Is it reliable?
It's subjective, meaning it relies on you responding, so it's often repeated to confirm defects and track changes over time. There are faster screening versions too. And in NTD, the defects might appear closer to the center earlier on.
Sounds like a pretty thorough check. Are there even more advanced technologies? Imaging?
Oh yes, we now have amazing optic nerve and nerve fiber layer imaging. These give objective quantitative measurements.
It's like OCT.
Optical coherence tomography, OCT, is the most widely used now. It uses light waves to create incredibly detailed cross-sectional images of the optic nerve, the nerve fiber layer around it, and the macula.
And it measures thickness.
Precisely. It measures the thickness of these tissues and compares them to normal values for your age. It can often detect structural loss before you lose any vision on the field test.
Pre-parametric glaucoma, you called it.
That's right. Allows for earlier detection or spotting progression sooner. Newer OCT angiography, OCTA, can even visualize blood flow in the nerve.
What about other imaging?
There's confocal scanning laser ophthalmoscopy, like HRT, which maps the optic nerve head topography, and scanning laser polarimetry, like GDX, which measures nerve fiber layer thickness using polarized light, though OCT is more common now.
Are there other tests sometimes used?
Electrophysiological tests like PRG or VEP can detect early functional loss of the ganglion cells, but they aren't routine in most clinics yet.
So it sounds like doctors have a really powerful set of tools now.
They do. But the key is putting it all together. Integrating findings from the pressure check, the angle exam, the nerve appearance, the visual field, the OCT scans, all within the context of the individual's risk factors.
It's a comprehensive assessment, not just one number.
Exactly.
Okay, so if glaucoma is diagnosed, what happens next? What are the treatment options? What can be done to save sight?
This is absolutely crucial. The main goal of all current treatments is to prevent further optic nerve damage.
Not restore lost vision.
Unfortunately, no. Vision already lost to glaucoma can't be brought back with today's treatments, so the focus is on stopping or slowing down the progression.
And how is that done?
The only proven effective strategy we have right now is lowering the intraocular pressure, the IOP, even in normal tension glaucoma.
Lowering the pressure is always the goal.
Yes. And treatment is usually lifelong. It often involves a combination of therapies over time.
What's the usual order of treatment, say for open-angle glaucoma?
Typically, we start with medications, usually eye drops. If drops aren't enough or the glaucoma worsens, then laser treatments might be next.
And after laser?
If needed, then incisional surgery. For angle closure, though, laser iridotomy is often the first step, especially in an emergency.
And the target pressure isn't the same for everyone?
No, it's individualized. The doctor sets a target IOP based on your specific situation, how bad the damage is, how fast it's progressing, your age, risk factors. Regular monitoring of IOP, the nerve, and visual fields is essential to see if the treatment is working.
Let's talk about medications first. The eye drops. How do they work?
They generally work in one of two ways, either reducing how much aqueous fluid the eye produces or increasing how well it drains out.
What are the main types?
Prostaglandin analogs, or PGAs, are often first line for POD. Latanoprost, bimetoprost are common examples. They're very effective, lower IOP by maybe 25–33%, usually just once a day at night.
How do they work?
They increase outflow through a secondary drainage pathway called the uveoscleral pathway. Side effects are usually local redness, eyelash changes, maybe darkening skin around the eye, or iris color change.
Okay. What else?
Beta blockers, like timolol. These reduce aqueous production. Used once or twice daily. They can have systemic side effects, those slower heart rate, lower blood pressure, issues for people with asthma COPD.
Right, need to be careful there.
Alpha-adrenergic agonists like bromonidine. These do both reduce production and increase uveoscleral outflow. Usually dosed 2–3 times a day. Can cause allergies, dry mouth, fatigue.
Okay, more options.
Carbonic anhydrase inhibitors, or CAIs. Dorzolamide, brinzolamide are drops. Acetazolamide, methazolamide are pills. They reduce aqueous formation. The pills are very potent, but have more side effects like tingling, fatigue, kidney stones, so usually used short-term, like for acute angle closure.
Any newer types?
Yes, rokinase inhibitors like netersutil. These increase outflow through the main drain, the trabecular meshwork, once daily. Can cause redness.
And older ones?
Miotics, like pilocarpine. These increase trabecular outflow by making the pupil smaller. Older drugs, need multiple doses, can cause blurred vision, brow ache. Still used sometimes, especially in acute angle closure.
That's a lot of different drops. Do people often need more than one?
Very often, yes. Using combination drops or multiple different types is common to get the pressure down to the target level.
And sticking with the drops is important.
Critically important.
Yeah.
Adherence taking the drops consistently as prescribed is a major challenge, but absolutely key for successful management.
Okay, what about laser treatments? When do those come in?
Lasers can be very effective. Selective laser trabeculoplasty, or SLT, is common for open angle. It targets cells in the trabecular meshwork to improve drainage.
Is it painful?
Generally painless, done as an outpatient, and it's often repeatable if the effect wears off. It's widely used and cost-effective.
What about for angle closure?
That's usually laser peripheral iridotomy, or LPI. The laser makes a tiny hole in the iris to relieve the pressure buildup that causes the angle to close.
That's the emergency treatment for an acute attack.
Yes, and it's also done preventatively for people with narrow angles at risk of closure. Quick procedure, standard of care.
Is there laser to reduce fluid production?
Yes, laser cyclophotocoagulation.
Yeah.
It targets the ciliary body, where the fluid is made, usually reserved for advanced or refractory glaucoma, or painful blind eyes. It can be done through the sclera or endoscopically during surgery. There's also a gentler micropulse version.
And if drops and laser aren't enough, surgery?
Yes, incisional surgery is for when medications and laser fail to control the pressure or progression. The goal is to create a new drainage pathway.
What's the traditional surgery?
Trabeculectomy. It's been the gold standard for decades. The surgeon creates a flap in the sclera and an opening into the eye, letting fluid drain into a little blister, or bleb, under the conjunctiva.
Is it effective?
Very effective at lowering IOP. Often uses anti-scarring agents like mitomycin C to keep the drain open. But it has risks. Infection, low pressure, hypotony, leaks, cataract formation.
What if trabeculectomy isn't suitable or likely to fail?
Then glaucoma drainage devices or tube shunts are an option. An Ahmed valve or Beervelt implant, for example. A tiny tube goes from inside the eye to a plate placed further back where fluid gets absorbed.
When are tubes used?
Often in complex cases, neovascular glaucoma, uveitic glaucoma, previous failed surgery. Their effectiveness is often similar to trabeculectomy.
I've heard about MIGS lately, minimally invasive glaucoma surgery.
Yes, that's a big area of development. MIGS involves newer devices and techniques that are less invasive, generally have faster recovery, and fewer complications compared to trabs and tubes.
But maybe less pressure lowering?
Generally, yes. MIGS often provides more modest IOP reduction, but with a better safety profile. They're frequently done at the same time as cataract surgery.
Can you give examples?
Sure. Devices like the iStent or Hydros microstent improve trabecular outflow. The Athengel stent creates drainage to the subconjunctival space, like a mini trab. Techniques like Cahook dual blade or JET-T physically remove or bypass the trabecular meshwork,
They're widely available.
becoming more common, especially in developed countries. But cost and training can be factors.
What about surgery for babies with congenital glaucoma?
That involves procedures like goniotomy or trabeculotomy, trying to open the natural malformed drains. If those fail, trab or tubes might be needed.
And cataract surgery itself can help.
It can lower IOP mildly in POAG sometimes, and in angle closure or narrow angles, removing the bulky lens definitely widens the angle. Sometimes removing even a clear lens is the best treatment for angle closure.
It really sounds like a tailored approach is needed for each person.
Absolutely. It's a constantly evolving field, matching the right treatment intensity to the individual's needs. The key is preserving vision long term.
So we've covered medical and surgical treatments thoroughly. What about lifestyle? Things we can do day to day.
That's an important question. Lifestyle modifications are definitely good for overall health, but it's crucial to see them as complementary to medical treatment, not replacements.
They don't replace the need to lower IOP.
No. Proven IOP-lowering therapies are the cornerstone, but lifestyle factors might play a supportive role.
Like diet. I've heard about leafy greens.
Yes, diet is interesting. Some studies suggest diets rich in leafy green vegetables might be linked to lower POA risk.
Why?
They contain nitrates, which the body can convert to nitric oxide. Nitric oxide might improve blood flow, possibly even aqueous outflow. Antioxidant-rich foods, fruits, veggies with vitamins A, C, E, might help combat oxidative stress, which could play a role.
Omega-3s too.
Omega-3 fatty acids are good for overall eye health, but there's no specific glaucoma diet proven to cure or prevent it. A healthy, balanced diet is always good advice.
What about exercise? Good or bad?
Regular, moderate exercise is generally great, good for circulation, but people with glaucoma should probably talk to their doctor. Some really strenuous activities or prolonged head-down positions might temporarily spike IOP in some individuals.
And smoking. Obviously bad.
Definitely avoid smoking. Damages blood vessels, increases oxidative stress, bad all around, including for eyes. Getting enough sleep is important too.
And sleep apnea.
Obstructive sleep apnea is linked to glaucoma risk. If suspected, getting it evaluated and treated is important. Also, IOP naturally fluctuates, often highest at night or early morning.
Does stress play a role? Can meditation help?
Direct causation isn't proven, but chronic stress impacts health generally. Stress reduction techniques like mindfulness meditation might be helpful for well-being. One small study suggested meditation might slightly lower IOP, but much more research is needed.
So healthy lifestyle supports eye health, but doesn't replace treatment. What about all those eye health supplements advertised everywhere?
Supplements. Need to approach this with real caution. While some vitamins and minerals are vital for eye health, usually obtained from diet, the scientific evidence for specific supplements preventing or treating glaucoma is generally not strong. Large-scale, high-quality trials are mostly lacking.
So talk to your doctor first.
Absolutely essential. Discuss any supplement you're considering with your ophthalmologist before starting. Supplements aren't regulated like drugs. Quality varies, and they could interact with medications or cause side effects.
And relying on them instead of treatment is dangerous.
Very dangerous. It can lead to delays in effective care and irreversible vision loss. Be skeptical of big claims.
Got it. What about other complementary therapies? Acupuncture, herbal remedies like ginkgo.
Research on things like acupuncture or herbs like ginkgo biloba for glaucoma is pretty mixed or inconclusive so far.
No strong proof.
Not robust scientific evidence showing a consistent, significant impact on lowering IOP or slowing progression. Again, discuss openly with your ophthalmologist. These should never replace standard medical care. May be supportive at best, but never the main treatment.
Clear message. Stick with proven treatments, be cautious and informed about alternatives.
Okay, let's shift to the future. What's exciting in glaucoma research? Oh, the future is really dynamic and hopeful. There's a ton of work on genetics and genomics, finding more risk genes, aiming for better risk prediction, maybe even personalized therapies down the line.
Understanding the why better.
Exactly.
Yeah.
Also, looking at neuroinflammation and the immune system's role in the nerve damage,
Mm.
delving deeper into the cellular mechanisms. Why do those RGCs die?
And looking beyond pressure.
Yes, investigating IOP-independent factors more. Things like cerebrospinal fluid pressure around the nerve or just inherent nerve vulnerability.
And the really big goal, protecting the nerve cells.
Neuroprotection. That's a major focus, developing therapies to directly shield RGCs from damage, regardless of pressure.
And even restoring vision.
Neuroregeneration and vision restoration. That's the ultimate ambition. Finding ways to regrow damaged axons or replace lost cells using stem cells, for example.
That sounds incredible. Is it close?
It's a very ambitious long-term goal. Significant hurdles remain. But our understanding is advancing so rapidly, there's genuine optimism.
What about things happening now? Clinical trials, new therapies being tested.
Lots going on. New drug classes like ROCK inhibitors, drugs targeting other pathways, aiming for better IOP lowering, maybe neuroprotection, fewer side effects.
And surgery. More MIGS.
Yes, ongoing refinements in MIGS techniques, continuous improvements in diagnostic tech to better OCT, AI analysis to help detect and monitor progression earlier and more accurately.
AI can help read the scans.
Potentially, yes. Gene therapy is showing promise in early stages, delivering genes to protect cells or improve outflow.
What about making treatment easier for patients?
Big focus there, too. Sustained release medications like tiny implants releasing drugs over months to reduce the burden of daily drops.
Drop-free glaucoma therapy.
That's the idea. Also, efforts to make traditional surgery safer, exploring MIGS for more stages of glaucoma. Targeted therapies for specific molecular pathways. Smart devices like contact lenses that monitor IOP continuously.
Wow. Stem cells.
Being explored preclinically, maybe to deliver protective factors or even regenerate the trabecular meshwork. Diagnostics keep improving higher resolution OCT, home IOP monitoring devices, searching for biomarkers.
And using technology like telemedicine.
Yes, digital health and telemedicine for remote monitoring, even things like low-level light therapy, are being investigated for potential neuroprotective effects.
It really sounds like future management will be much more personalized, less invasive, maybe even transformative.
That's the direction, combining effective IOP lowering with direct neuroprotection, intervening earlier, and hopefully eventually having regenerative therapies to repair damage and restore lost sight.
An incredibly hopeful outlook. Okay, finally, let's circle back specifically to family history. You said it's a potent risk factor. What should someone do if glaucoma runs in their family?
Yes, having glaucoma in the family, especially first-degree relatives, parents, siblings, children, significantly bumps up your own risk. That makes being proactive absolutely critical.
So what are the key steps? Number one, must be getting checked.
Absolutely. Early and regular comprehensive eye exams. Start by age 40 is the general advice, but if you have a strong family history, especially if relatives were diagnosed young, consider starting even earlier, maybe 20s or 30s, for a baseline.
And how often after that?
Every 1 to 2 years, or whatever your eye doctor recommends based on your specific risk. And crucially, tell your eye doctor about your family history. Make sure they know.
So they can monitor more closely.
Exactly. And encourage your relatives, siblings, adult children to get screened too. They share the increased risk.
Be aware of symptoms too, especially angle closure.
Yes, even if the family history is open angle, know the acute angle closure symptoms. If you are diagnosed with glaucoma or ocular hypertension,
Stick to the follow-up schedule.
religiously. And if treatment like eye drops is prescribed, use them exactly as directed. Communicate any problems or side effects to your doctor.
What about lifestyle stuff for prevention?
Healthy lifestyle choices, blood pressure, exercise, no smoking, eye protection are always good for overall health. But there are supportive measures, not direct prevention for glaucoma itself in someone high risk.
Education is key.
Understand your personal risk. And know that genetic testing might play a bigger role in refining risk assessment in the future.
So, for those with family history, be proactive, get screened early and regularly, communicate with your doctor.
Precisely. Vigilance and early action are the best defense if glaucoma runs in your family.
Well, this has been an incredibly thorough deep dive. We've covered so much what glaucoma is, the types, causes, risks, diagnosis, treatments, lifestyle, the future.
It's a complex topic, but hopefully we've broken it down.
I think the key takeaways are it's more than just high pressure. Early detection is vital because it's silent. Lowering IOP is the main treatment goal now, and research is moving fast with real hope for the future.
And please remember those regular comprehensive eye exams. They're not just for glasses. They are critical for catching silent diseases like glaucoma, especially if you have risk factors.
So let's turn this knowledge into action. What are some practical steps listeners can take away today?
Okay, first, if you haven't had a comprehensive eye exam recently, especially if you're over 40 or have that family history, schedule one. Make it a priority.
Good advice. What else?
If you do have a family history, talk to your relatives. Encourage them to get screened. Share what you learned about the increased risk.
Spread the word.
Maintain a healthy lifestyle, including those leafy greens. If you are diagnosed, stick to your treatment plan, rigidly drops, appointments, everything.
Be critical of alternative therapy claims.
Yes, very critical.
Hmm.
Always discuss them with your ophthalmologist first. And maybe consider supporting glaucoma research or awareness efforts if you feel strongly about it.
Excellent practical steps. And as we wrap up, thinking about the future, it's inspiring, isn't it, that we might move beyond just slowing progression.
Towards neuroprotection, maybe even vision restoration. It's exciting to think what new possibilities might emerge as we understand glaucoma better and develop truly regenerative therapies.
A really hopeful thought to end on. The story of glaucoma is definitely still being written. There's genuine hope for a brighter future.